Hello, GP learners, and welcome to this episode. Myself and Andy are going to be reviewing the new update to the PCN DES contract for October 2024. It's a little bit different because we're going live on a Sunday morning, and also on top of that, there's some weird changes that you may or may not have even figured out from this document, including the big thing that everyone's talking about, which is the GP and ARRS, which actually has a different name. So let's get cracking as we take enhance your primary care and learning. Hello, GP learners, and welcome to this extra special update episode for myself and Andy talking about the PCN DES update October 2024. Gosh, that's a mouthful, Andy. How are you doing there today?
It is, yeah, I'm pretty good. So Gandhi, you've pressed the emergency podcast button this morning and made us go live. Well, not made us, but made it happen for us to go live on Sunday morning. And it's great to see that people are watching. And actually, I think this is actually quite a big change. We normally have quite a lot of fanfare around changes to the network DES of this gravity, but it's all kind of slipped out a little bit sort of quietly at the end of last week.
It has.
Yeah, so doing it a bit differently this time, Gandhi, haven't they? So what's been different about this update in terms of how you've found it?
Well, I guess the typical thing when we get an update to the PCN DES contract, there's normally a letter, there's normally an executive summary, there's all the details being explained and stuff. And this time there hasn't. In fact, even to find the actual letter, it's not even been republished. It's just been updated. So normally me and Andy show you where you can get the letters, and you go to the NHS England publications page, and it's normally the first one on the first page because we try and do it as quickly as possible. But actually this time I couldn't find it. And I had to search for it. And actually the one it comes up from is the original document in March, which I don't remember it being that way on previous updates. And as you mentioned, Andy, there was no letter this time.
It's really strange, isn't it? I mean, you wonder why. So I guess there's new management, right? We've got a new party in government and a new health secretary. And I guess there's been a lot happening, I guess, in NHS England. They're there's been the party conferences coming up. Everybody's been very, very busy. So maybe that's why. But it is helpful to get that summary letter, isn't it? And actually, we had to dig around a little bit to in our hard drives to find a copy of the old DES, because they've just sort of replaced the old one with the new one in the on the NHS website. So, but we'll be having a look at it all and trying to work out what it means for everybody's primary care networks, and for those GPs who might have been looking at these opportunities in primary care networks and thinking if it's for them. So
just to give you an update in terms of what this episode is going to look like. So the first thing we're going to cover is the core funding aspects. So there have been some changes in terms of what funding networks will be getting as a result of that. Then we're going to talk about the ARRS, as it's now called, so the Additional Role Reimbursement GP Sum Scheme, which is just a weird acronym, and everyone knows it as the GP and ARRS basically. Then we're going to talk about ARRS itself, so the normal Additional Roles Reimbursement Scheme, because they are separate, remember that. Then rather briefly, we're just going to talk about a couple of changes additional to the DES contract. So in particular, there's a change to IIF and stuff and things. And hopefully we'll cover all of that. If you do want to comment and stuff, please do, because we would really like to know your thoughts on this as we go along. And also, as usual, like and share, blah, 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 all that kind of YouTube-y stuff that helps to get this to further people and stuff. And I need to try and stop saying and stuff. I've been commented on this, Andy, that I say it loads, particularly increasingly. And it's my way of avoiding saying So
you need a new phrase.
I need a new phrase. Yeah.
A new exclamation.
Yeah. Well, let's talk about the core funding first of all. So this is the base funding that the PCN DES is getting. Now, myself and Andy, what we've done for this is we've got the two different contract versions. So we've got the one from April and we've got the one from October side by side. You could argue, if you really wanted to be dedicated, we could have also had last October's up. But to be honest, we're doing this on Sunday morning. We've just not had time to compare it, have we, Andy?
No, I mean, it'd be nice to, if we could do a chart that shows the growth in ARRS funding in all the different areas, and DES funding, and maybe we will one day, but we haven't done it.
We'll see. Cool. Okay, so let's take a quick look. So these are the two different documents. Andy, do you want to walk us through which one's which?
Yeah, so on the left, you have the September 26 updated DES, and then we have the one on the right from April 2024. So 26th of September 2024. I think I said 2026. That's in the future. That's for everybody. And then we'll just work through and helpfully where things have changed from the previous document. NHS England highlight in yellow, which is really, really helpful for doing analysis of these documents. So I've just skipped down to section 10, which covers the financial entitlements. And then I'm just, Gandhi might need to do a bit of fill in as we, there we go. So we're finding the tables that show the kind of headline funding for primary care networks. And we've done a little bit of comparison, haven't we, Gandhi? So I know you've looked at the first figure for core funding, and I think the participation figure is somewhere in here as well. I don't think it's in this table, but has what's happened with the participation?
Remember on the participation payments, this is the payment given to practice for participating, as it says, within the network DES. This is still, if I remember rightly, £1.761, I want to say.
So that's never changed, right? From the beginning?
Never changed throughout
since 2019, that hasn't changed.
Yeah. So I guess if people are looking at comparisons of funding that general practice gets, that's one that over the past 6 years has not changed, has not increased, no inflationary rise at all and stuff for networks participating in the DES. Obviously, if your practice population has increased, which a lot of practices generally have to some degree, then you would have received more funding because it is per registered patient at your practice. But just a key point that particular payment rate hasn't increased in this particular year. So you, as a practice, you are still paid the same amount as you would have been done back in 2019 for participating in the DES. And, for an average practice population of 10,000 patients, for example, you're talking just over £17,000 worth of funding for engaging with the PCN DES. That is separate to the PCN core funding, which is what we're going to talk about right now. Now, important to remember that in April, they made some changes to the way the core funding works. So previously, people used to refer to this to the £1.50. You remember that, Andy?
I do. That's what we always used to talk about. Yes. Yeah.
And in April this year, it was no longer £1.50. It became a different amount because they combined that funding, that core £1.50 funding that networks got to run the network, with some of the other pots of money like the leadership and development funds and the SDF funds and stuff that the networks had. And as a result of that, it became the new amount, which is on the right document, which was, and I can't remember, £2.
£2.916. Sorry if these are a little bit small, but it's difficult showing both documents.
In fact, let's see if I can make those a bit bigger for everybody. That should work.
I'll do my best this end as well. Might be a little bit.
Yeah.
Oh, that's too far.
So so it was changed to £2.916. There was some increase, and this is the part me and Andy haven't quite got around to figuring out for everybody, so apologies on that. But the difference is from October onwards, backfilled. They are changing this amount to £2.967, which is approximately it's a 5.1 pence increase from before. So approximately that's about £2.5 for a 50,000 patient network. Does that make sense, Andy?
That does make sense, and that's about 4%, right? That's okay.
It is it's actually about a 1.7% increase.
So okay, that's fine. Sorry, I know. Sorry, my gosh, it's too early for me, Gandhi. I was doing crazy maths there. Yeah, good. But it's useful to know the percentage increase, though.
Unfortunately, it's not as simple as that, because they've also done it in different ways. So effectively, what they've done, there's two pots of money that create that amount. So there is the where are we? They've increased. I'm trying to
there's 2.2.
Yeah, so £2. So if you go to the previous amount, in total, £2.24.2 pence is then multiplied by the PCN registered list size as of the 1st of January, and then an additional 72.5 pence is multiplied by the adjusted population as of the 1st of January. So they are slightly different metrics that you need to use to calculate those amounts. And that's because of the combination of the two different funds and things that we talk about. And you can see that direction in the right-hand page where it talks about this combines the funding previously labeled as core PCN funding, clinical director payment, and the PCN leadership funds.
Yeah, I think the second figure, that 72 pence, I think that's the old leadership and management payment. I think.
I think that's that's the PCN clinical director pay.
Oh, is that what that one is? Okay.
Yeah.
I thought the first one had combined the clinical director payment with The core. Okay. I tap out. Okay.
So the reason why that's important to note is that there is an increase. It's a modest increase at best, 1.72%, I believe I calculated as for the whole amount compared to what it was from April 2024. I don't remember that being a huge increase this year in terms of the funding that networks got either. So if someone who's watching has calculated that and wants to let us know, please do. Unfortunately, me and Andy just didn't have time to do that this morning whilst we were getting ready for this episode, because we spent a bit more time figuring out the GP stuff and things, which we're going to come to shortly. However, there are other increases that have happened as well. So Andy, you're going to take us through the enhanced access and care home payments, weren't you?
Yeah, so if we look at the next bit on the table, so enhanced access and enhanced access payments have gone up by about 30 pence. So from 7.67 pence from in the last year's DES to 7.975. So that's an increase of about of 30.1 pence. That's about a 3.9% increase. And if you multiply that 30 pence by 50,000, that's about 15k for a 50,000 sized primary care network. So, not insignificant. What do you think about that, Gandhi? Does that make a difference?
I mean, it's a useful increase.
Yeah.
Any increase, let's be honest, is a great and appreciated increase. However, it's still by no means inflationary matching and stuff in terms of the costings that people have to pay for.
And in an environment of 6% pay rises as well. There's the expectation of probably the clinical staff delivering those. It's probably not quite keeping pace. It's a shame, isn't it, where we sort of feel positive about receiving sub-inflationary increases to contracts and sort of find that unexpectedly positive, but that's where we are. So enhanced care and care home. So the care home premium has increased from £120 in April 2024, and it had been £120, I think, from the introduction of that scheme, to £127.20 from October this year, going forwards to the end of the year. Which is a £7.20 increase. So that's interesting. That is a 6% increase. That is a round 6% increase of the figure. And if, say, a primary care network like my primary care network, we have nearly 400 beds, care home beds in our primary care network, and that's an increase of about 2,800 there, which is 6%. So I think that's good. I'm quite pleased with that, to be quite honest. So
interesting to know that's the first time they've increased the amount since the care home DES came out. Care home DES adjustments came out during COVID and things. So that's the first time they've actually increased those levels as well.
Yeah. And then capacity and access payments, I don't think there's been a change there. There's no change indicated in the document. So just marking that.
Yeah. So when we looked at the different levels, like I said, these were the different amounts we found in terms of changes and things for the core funding. And the reason why I suspect there's no more further changes is because the next section that they want to, that we're going to look at and that everyone has been talking about is the GP&Rs. So this is the funding pot that was announced by Wes Streeting pretty much within a few days of him coming into power, and possibly with a view to trying to stem off collective action. Obviously, that hasn't changed collective action in terms of the direction that NHS England, the GPC have been directing it with for a lot of places, because it's interesting to see how many places are and are not engaging with that. And we've talked about that in our previous episodes. But this is the detail that many networks have been waiting for to understand how they can include GPs within the ARRS funding and what that will mean. And we're going to cover that for you right now. And it's a corker in it, Andy.
Yeah, it's interesting. And I think it will be hotly debated quite how to use the money and how impactful it will be in the end. But yeah, do you want to lead us through the main bits, Gandhi?
Will do. We'll get to that. So we've had a comment from Papa 909. I'm not going to bring it on screen, but just to ask Papa 909, if you just clarify what you mean, you're just about to ask about this. Was that the GP&Rs scheme or something else? Sorry, just because of the timing and stuff, not quite sure what.
Feel free to just ask away. That's
just ask the question of what it is in detail. We'd love to hear that and stuff. But yeah, so we're going to talk about, like I said, the GP&Rs. In terms of looking at this, so Andy's hopefully got it on screen now. And Yeah, go for it, Andy.
Okay, you spent more time with the actual document. I've had a look at some of the summaries.
Sorry, I thought you were going to come in there. That's fine. So first thing to say is that actually this isn't in the previous document, so we probably don't even need to look at that one, to be honest, because it wasn't mentioned there.
Yeah, we'll bring that back to look at the ARRS reimbursements.
So we'll bring that back a bit later on. We've probably done this in the worst way possible for Andy today in terms of screen sharing, and I apologize. That's my fault, everybody. I just thought this is the part that people probably wanted to hear more about. Should we just zoom in a little bit, Andy?
Yeah.
So there's a few structural changes in terms of the document because they've had to move things around because they've added this extra section. It's 10.4 and 10.5, if I remember rightly, that you need to focus on. And effectively, it talks about all the subsection changes and stuff. I think we probably need to go up, Andy. I think it was 10.4, wasn't it?
Hang on.
Have I got it wrong?
I think we're back at the DES there. Hang on. You probably mean down. Let's have a look.
I mean down. I apologize.
This is what you get for this is what we get with an emergency podcast on a Sunday morning. Although it's really important that we get this information out because we were surprised by some of this information and the changes in the DES and changes to the ARRS reimbursements, which no one's talked about. We'll get to that later, though. GP and ARRS for the moment.
So first thing that you can see there, that yellow section 10.5.4a. So it tells you how much networks are going to get. So the GP, so the additional role. Sorry, you're going to pass to Andy. There you go. So they're calling it the additional roles reimbursement GP sum. Like I said, ARRS is the new acronym, and it equates to £1 30.3 pence multiplied by the PCN contractor weighted population list. So this is a weighted population list. It's not the adjusted list. It's not the raw list. That's the list you need to use as of the 1st of January 2024.
So if you have 50,000 patients in your primary care network, that is £65,150 that you will have to spend on your GP and ARRS person or role. And that's obviously before you subtract on costs as well. So we generally assume that on costs are about 30%. So these are the costs that the employer pays, the cost of employing that person. So employer's pension contribution, national insurance contributions like that. That it's not the money that the person doing the job gets in their pocket. That's about 70% of that. So that would work out about £45,000, 605 pence sort of available to go into the pocket of a GP. Obviously, they then have to pay their pension contribution and their tax, from that as well, of course. But that's what they would see as their salary. So not an enormous amount. But
no, well, you could argue that's a very challenging amount because if you equate to how that may work locally in your area, and I guess that's the difference. So this is the national rate that we're talking about. I think there's some adjustments being made for in London and out of London, aren't there, Andy?
There are. So they quote the funding in a different way somewhere else, but essentially they were saying that this equates to these are comparative figures, so £92,500 in I think this is just nationally to about 95,237 in London. I'm not sure whether that's the inner or outer London rate, Gandhi. Those are the two figures that I jotted down here, but there is an adjustment for London, so I think that's the thing to take away. And if that applies to you, then apply that. Again, I was just thinking about 45,000. So if we sort of, I think, salary GPs, it varies around the country, but if you're sort of thinking, say, £10,000 per session per year for a salary GP, something like that, that's about 4.5 sessions per week for somebody working across potentially a number of practices, or depending on how they'll structure that. And we might talk about what people might be doing with this funding and how they'll be structuring that GP's work later, but it's not half time across a number of practices. It's potentially tricky to do something meaningful with that as well, isn't it, Gandhi?
Oh yeah, definitely. I mean, one of the key comments that have come around in various forums and different aspects of this is the level of funding and how that equates to a traditional model, and how will that work, but also in terms of equivocal pay for clinicians. And the reason why this is really important as well is when you get into the detail of what the GP and ARRS actually looks like in terms of the type of person you can actually employ, which we're going to cover now. I know there's some questions coming through, which we will come to, and hopefully we'll cover all those points that people are making in the chat in a second, and we'll bring them on. But I think it's important we just get to those criteria points first, because that'll help to set up why some of this is a key issue and things. So I think that's the ARRS funding. Yeah, it was section 7, if I remember rightly, Andy. So I think we actually have to go back up.
Thank you. Direct me. Let's go back to the contents page.
There we are.
Yeah, 7.3, I think it is.
Apologies. This is why this one's a little bit choppy, because you have to jump around a little bit to get to this section. So as you can see there, they've named the second pot, the additional roles reimbursement GP sum. So to bring on Arjuna Yoga's question, is the ARRS GP sum in addition to the ARRS budget? Yes. However, as per previous comments and letters that we've had, you can't use the ARRS funding to supplement the ARRS GP funding, and vice versa. They are completely separate pots of money, completely separate pots of reimbursement. So you can't blend them over in any way, shape, or form. They're NHS England in this document are very clear on that point. Any comments on that, Andy?
No, I don't think so. We've got some other useful comments. I know Varun Rimple's asking, is this amount for 6 months or a year? And you just made me stop to think. I've been assuming that these are annual annual amounts. But
so good clarification point, and thank you for the question, Varun Rimple. But that is for 6 months. So that is for, and the reason why that's for 6 months is that there is the anticipation and the expectation that actually this will be rolled into next year's DES contract, so the 25-26 contract, and therefore this is only a 6-year time period. So I have clarified that with some GPC people, because everyone was just like, well, is it 6 months? Is it a year? Because that makes a massive difference. So that is 6 months. That does make the funding sound a lot better.
So is that right? So these figures are for 6 months, so we can multiply these by 2.
Yeah, so you double the rate, which is why you do get to 9 sessions. But again, it comes down to the level of funding that we've got and stuff and things. So we're being asked if we've got a direct link to the websites by a couple of people. We will put those in the show notes when we finished. Unfortunately, I can't do it whilst we're streaming, but we will do that. In fact, I'll see if I can get a link into the chat.
Arjuna Yoga, I think, sorry, I just noticed something coming in. So, So I think those figures are 12-month figures. So I think we're dealing with these on the fly a little bit, Gandhi. But I think that those are sort of representative of sort of 6 month salary figures.
So just to clarify, from our understanding and from the conversations we've had so far, the amount of funding, the £1.303 per patient, is for 6 months period, that will then allow you to use that up until the end of March 2025. The 92,462 is the equivocal amount it would be for an annual pay rate based on effectively the BMA model contract, is what you need to use as your yardstick to understand how that money can be allocated and for each individual person. And the reason why they've done that, so quite rightly, I think to some degrees, NHS England have said, well, if we're going to use a model contract for this person, where are we going to look at? Well, they're going to look at the BMA model contract. The question of how appropriate is the BMA model contract is a separate point. We're not going to discuss that in this session because that's a whole other kettle of fish. But, and I do want to get onto this point because this is the key thing for many people that you do need to understand. There are criteria for what the individual taken through the ARRS GP scheme can and should be. So I think we need to scroll down a little bit more, Andy. And these have been bandied around. We knew about some of these in some way, but we've had the clarification, which is what this is. It's the big yellow section. I think you have to go down a little bit. There we are. So here we are. PCN may claim reimbursement for general medical practitioners from within the additional roles GP scheme sum in accordance with terms set out in this section. So they have to have been substantively employed as a GP medical practitioner previously, subject to an agreement to a commissioner. Okay. Sorry, except where. So they can't have done this. Apologies. I made this. I knew that. It sounded wrong as I read it, and I remember why. So basically, if the individual has had a previous substantive position, so for example, a salaried or a partner role, they can't be included in the GP sum scheme. Does that make sense, Andy?
It does. The wording's a little bit it's a little bit tricky, isn't it? So
what they should have done is except where they should have made that bold and underlined.
Yeah,
because until you read that bit, you kind of start thinking, well, it's only somebody who said a previous. And the reason why they've done this, and my understanding of this, is that it means that you can't transfer existingly employed GPs into this scheme. Categorically to prevent that from happening.
That's in the principle of the additional roles reimbursement scheme in general, isn't it? There was concern about pharmacists, particularly initially in 2019, being moved onto this way of paying them, so that in fact they weren't additional, they were just the same people as before, but being paid by new funding. So Section B, they can't be a locum. Essentially, we're dealing with
so they can be a locum, but they can't be employed for a locum purpose through this role. So you can't, for example, take them on as a locum contract.
Now, apologies, that's what I meant, Gandhi. They can't be employed as a locum. But
this is slightly confusing, given the fact that you can technically employ them for up to 6 months. So this is where it makes weird sense and stuff, because unlike all the other ARRS roles contracts, which we will come to, there it states that the ARRS roles must be employed for more than 6 months. So they can't be offered short-term contracts unless it's to cover specific things like maternity leave, sick leave, etc. and things. However, for the GP ARRS, you can, because of the fact that this particular pot of funding is only up to 6 months. And this may be, I wonder, in terms of an anticipation of, we don't know what's going to happen April onwards. But there is the anticipation, it seems, from NHS England that this is a role that will continue, because the direction that they have said so far is that this will be rolled into the PCN DES contract from April onwards, so that person can continue employment. And the third part, which is the other one, is that the person taking on the role can't be more than 2 years since their CCT at the start of their employment. So this is one thing I wanted to clarify, which actually rereading the document has made that more clearer to me, that if you want to take somebody onto this role, when they start the role, they have to be at least 2 years less than their CCT date. However, if they were to be, say, for example, 1 year and not 10 months, you can still keep paying them in that time frame, because at the start they were under 2 years. Does that make sense, Andy?
That does make sense to me as well. So at the time that you recruit them to this role, they have to have been less than 2 years from completion of their training, essentially, just to say that in another way, so that it's clear. And I'm just checking that I've understood that with you, Gandhi, as well. And I guess part of the pitch of these roles is to in some way support newly qualified GPs through the GP workforce crisis, which is where, because of a lack of funding, there's a lack of work for newly qualified GPs in many areas. So that sort of fits with the spirit of what we've heard of the intention of this scheme as well.
So at this point, I'm just going to go to some of the comments we've had. So we've got a few of them. Arjun Yoga's come back with, thanks guys, quite confusing. The 1303 allocation for 6 months will be quite above the max annual FTE in the table. Our understanding is that part of the reason for that is because of how they equate full-time equivalent with GPs, but also the fact that, don't forget the amount that there is including. So that's all you get. You don't get on costs on top of that. So you have to take the on costs out of that. So what the actual individual gets is effectively 30% less. And that's how much the pay rate would then be that you offer the person. That's not the pay that you give them, because the on costs have to come from, this is a reimbursed amount. And it's important to remember that aspect, compared to normally when you offer a contract to somebody, you tell them the pay rate that they get, and then the business, the practice, has to add the 30% on top, roughly, for on costs. So our understanding is that's why it works out to the amount that you get from there. Does that make sense?
I think so, Gandhi. One thing I was trying to get my head around was whether they are sort of implying a rate of pay per session or hour for GPs. And the conclusion that I'd sort of reached on my own was that it doesn't look like they are. It looks like there's an allocation, and then you use that allocation to buy how much time you can buy with that in your local employment market. So that might be different in different parts of the country, and you might find that money goes further or not quite so far, depending on where you're recruiting your GPs. Do you feel I'm right in that assumption?
I believe
Andy?
so, and I think Varun Rimples come in with a similar question. So the 9462 is the maximum reimbursable to any individual GP. If you have a large PCN, you could employ 2 GPs as long as the funding equates to So if you are a large network, and there are some out there, then the maximum you can give any one individual is the 92462, or it's slightly higher inside London. I think it's 96 something. And therefore you then have to have a separate person taking the additional funding. To go to Nina's comments, and I know this is one that's frustrated many people. So only newly qualified or career locums who have never had a substantive role can be used. You're correct, Nina, in saying that doesn't help career locums who can't find work. Important to remember when you talk about career locums, they also have to be within 2 years of their CCT, so that they theoretically would not be classified, I guess, in some ways as career locums because newly qualified. But yes, if you've had a substantive role in the past, then unfortunately that individual cannot be used for the ARRS reimbursement scheme. And if found out later down the line, the networks run the risk of being subject to various other things. A couple of things that do come up. So there's a bigger section that talks about some of the exclusions and stuff. The main things that most of you probably anticipated. So it has to be somebody that's on the GMC register. It can't be somebody who's been suspended or withdrawn from the GMC register at a previous point. They can't be somebody who's got any restrictions on them in terms of practicing and how, any kind of issues in that sense from either GMC or on the performers list, is my understanding of some of the weird and detailed legal terms that they've used in some of this. So just to be clear on that point, it has to be somebody who can actively work, who is never been disqualified or suspended by the GMC and has active performance lists with no restrictions as well. So those are some extra clarifications. There's a big yellow section, Andy. I don't know if you can find it and stuff that covers that, but it's basically that's what it means.
I'm just skimming through. I don't think I've found that section yet, Gandhi, but I'm sure it's in there and highlighted in yellow if people want to follow.
Okay. Did you want to bring that bit on that you've got to, or were you just pausing there? Because
I was just looking for table 3C with some of the financial details in there. We can share what's on screen, but I'm just skimming through. This is talking about some of the London region issues and so forth, but
I think it's after that, if I remember rightly.
I didn't want to make people dizzy by skimming through the document on screen.
So I'll take that off as Andy tries to find the tables. I guess to go to some of the other comments whilst he's doing that. Mike Sheldon, PCSE will struggle to set up and make a deduction for pensions for the first 6 months. I mean, PCNs will have to hold on to pension money until requested by PD, which can take ages. Yeah. There is no comment as to how pensions are going to work with this. And as many anticipate, that's a really complicated scenario. So just to be aware, there may need to be some disaster planning for some of this and how that will work. Samir Shah's coming in. Is there anything on the DES about GPs who are still on their skilled worker visa restrictions? It doesn't mention that, but like I say, it does state that the individual needs to be actively enabled to work on the performers list. So I guess that's the key restriction I would look at in terms of how it works. And
I've got table 3C. It's just confirming those maximum reimbursement rates for the role in total, both nationally and with the London weighting. So we discussed those figures earlier, but table 3C is there. And all of these table 3 sections are so this is a new table that sits alongside the other tables giving the ARRS reimbursement figures. So it's in that section.
And that's probably a good point for us to talk about that. So if people do have more questions on the GP in ARRS, please feel free to stick them in. We'll come to those in a second. Right now, what we are going to do is talk about some of the ARRS changes that have happened. There's not a huge amount, but there is something to note here. So in terms of the ARRS changes, effectively, they have, and this hasn't really been widely televised, they have actually increased the reimbursement rates for the ARRS roles. Haven't they, Andy?
They have. I'm just getting set up on screen because we can share the tables side by side. So this is something which I don't think we'd seen announced anywhere, but it is actually quite significant because I think people were wondering, are those figures going to increase given the 6% pay award DDRB to many of the roles that work across primary care, the GPs and GP partners. So I'm still navigating. Just give me a second, Gandhi.
No problem. And I think it's important to recognize this, because originally when the documents, when the pay awards and stuff started coming out, there was a suggestion there would not be any support in terms of finding those pay differentials. It seems there has been, but we're going to come to the nub of this in a second. As usual, it looks like it's not quite enough. So we ready, Andy?
We are, yes. So we've got
we
come on screen. Yeah.
So we'll go at this document in detail. In fact, let me use the other view, because I think that's going to be better and easier for us to see. Let's go for
that
one. There we go.
So we've got the old document on the right, April 24, new document on the left, October, end of September 2024. And so now there's two tables for each section here. So we used to have in the old document, so table 2 was the maximum reimbursement amounts per role. And now we've got table 2 in the new document, where we've got table 2, table 3I, which sits after it, which gives, so basically in the new document, you have the rates from April 24 to September 24, and then you have new reimbursement rates from October 24 to the end of March 2025. So the last 6 months of this year, that's when they're increasing the reimbursement rates. So that's how the document works, if people want to have a look. And then helpfully, NHS England highlight, all changes in yellow, which helps us see that these rates have increased. Now, we haven't calculated the percentage increase for all of these. We'd had a look, say, for example, at clinical pharmacists, going from the national figure 62,340 to 65,838, and calculated that that's an increase of about 5.6%. So not quite 6, but 5.6%. And then if we take a non-clinical role, such as care coordinators, that has increased from 33,396 to 35,301. And that's a 5.7 increase. So we're looking at just sub 6% increases in, say, those two roles. We've noticed that the figures just slightly different. It's not always the same percentage there. But interesting that they've snuck that in without much fanfare, and that there has been, a substantial increase, really, or near inflationary increase in those roles. Reimbursements. Yeah, what would you think, Andy?
Yes. So first of all, an increase, and a substantial increase, I think, to be noted. Not quite the 6% that's bandied around for various other things. Other things to remember: this is effective from October onwards. This is not backdated, and this may be where some places need to consider the shortfall that comes through. So both in terms of, if you're allocating 6%, because that's the number that everyone talks about currently this year, then there's absolutely shortfall from there. Additionally, if that an individual within your network would be liable for that increase before October, there may be a shortfall there. Now, I wonder if part of that is because the DES is out of sync compared to various other employment aspects, because don't forget, the original DES started in August 2019. So in terms of employment points, they may be slightly different for individuals. I think this is something that networks will need to look at, either themselves if they're the employing organization, or if it's with federations or other groups and stuff, as to where individuals sit in terms of pay rises. Or they just say, well, this comes into effect from October, so that's when we can apply any increases. Or they take the hit directly by taking it from core funding, which will be interesting. We think every role has had an increase, but like Andy mentioned, not every role has had the same level increase as well. It is very much individual. And don't forget, that is the maximum reimbursable rate that you can apply for. So it doesn't necessarily mean that everybody can have the same increase. It's also based on skills and capabilities and stuff, where people may be allocated based on how your local systems work.
That's true. There may be people watching sort of in these roles, and it's not necessarily representative of the amount that you will be paid, because the PCN has to pay on costs, and as well, not everybody is working to the maximum kind of capabilities of each individual role. I think you did confirm this, Gandhi, but just for confirmation about whether there's been an increase in. So that's the wrong one. The total ARRS budget for a primary care network. So the individual amount that you can claim against individual roles has increased, but has there been an increase in the total pot that you can claim from?
From my understanding, reading this, there's not been an actual increase in the allocations that network receive as to how much their funding level is. The individual bandings have been increased to allow for inflationary pay rises, but the amount that the networks necessarily get, I don't believe has been increased at the same level. We haven't been able to find that in the document. If somebody feels that's different, please let us know, because we've struggled to find that in the time that we tried to analyze this.
And it's a really, really good question. So the follow-up question from Azar there was, so if you are at the top of your budget, drawing down to pay your staff, then actually these increases in what you're able to draw down for individual members of staff doesn't really help in terms of balancing your budget. And that's absolutely right. You would have to have a smaller workforce to then start to draw more money against individual roles to pay individuals more. So there'll be a sticky situation in many primary care networks, and this increase in the funding for individual roles may not make much of a difference. I think it's helpful, I guess, if you have some churn of staff. So when we say churn, people join roles, people leave roles for all sorts of reasons, not all of the negative reasons, and then that gives people an opportunity to reshape their workforce, perhaps reduce the headcount, but concentrate on retaining those people that they have by enhancing their pay according to these bands. So not completely useless, but yeah, you're right in pointing out that flaw or that difference.
And just another point to bring into this in terms of how the roles work, don't forget that the rules of additionality still apply. Now, although the additionality is predominantly focused on the pharmacists and the SPLWs, all the other roles still, and there is baseline data for that. They don't use the baseline data for a lot of the other roles and the GP roles. There is still the additionality clause on those aspects that NHS England potentially could ask ICBs to monitor and enforce upon networks. So it is important to remember that you kind of need to still be claiming additionality aspects and things with these roles. And yeah, it gets tricky from there. Just before we go to the final comments and questions, so if you do have more questions you want to ask us or comments you want to make, please do so. Just really briefly, I'm going to cover one other change, which is an IIF change, not IFF change. And that's relating to one of the criteria is CAN 04. Now, Andy doesn't have this on screen, and it's a fairly minor change because it's the only change that's come through from IIF. But effectively, this is the FIT testing for gastrointestinal cancer. They've changed the denominator for this, and I'm just going to try and read it because it's quite a little bit confusing. But effectively, where is it? I had it and I've lost it now. Apologies, everyone. It's in the annex. The details in the annex is on document B, on clinical guidance B. But effectively, the denominator now is where at least of the denominator, those where at least one urgent suspected cancer referral was accompanied by a fecal by a FIT test, with the result recorded in 21 days leading up to the referral. So I think the reason why they've made this change is effectively there have been lots of issues with FIT testing nationally, not just in terms of the availability, but also the way that it's recorded, because a lot of labs don't record the FIT test at the date the test is analysed. They record the FIT test result at the day it's requested, which then has an impact on the results actually coming through in an appropriate way. So they've changed it from a percentage of those to being at least one to help with the denominator, and therefore making it, from my understanding, slightly more achievable in terms of the rate. It is a little confusing. So again, if somebody understands that better than I do, please clarify it for us. But I believe they've made the FIT testing slightly easier to achieve because of the problems they've had with how the testing works nationally and the absolute categorical issues in terms of that works. And I know for Nottingham in particular, there's been a lot of work being done to try and rectify that process, that actually it was exactly that problem, that the fit test results were done at the time that the test was recorded, and therefore majority of times people were not captured properly, and therefore networks were not getting paid for the work that they'd already done, purely because of bureaucracy issue with the way the labs count for the results.
Yeah.
Andy?
I remember that was an issue locally. Was there a local resolution where they changed the reporting date to when it was processed? I think locally there was a local change in our local labs, but there was a lot of discussion around that problem. So I think this is really, really helpful.
So hopefully it should make it easier for that to be achieved for networks and stuff. So I've been asked a rhubarb by rhubarbs or hubarbs. Could you repeat that or post it in the chat, please? I will post the document in the chat, and what you need to do is go down to page 59 for the clear details. So I will post that for you. Just give me 2 seconds. So can go for
good.
There are some other sections higher up, but the key part, from my understanding, is page 59, and that's for rhubarbs or hubarbs. Love that name. So what else have we got? So Mike Sheldon mentioned, what about backdated pay for our staff? There is none. Simple. There isn't. So it's from October onwards. Unfortunately, networks will have to deal with that from there. And then Varun put in, is there a risk for PCN if the funding was withdrawn from April 25? Yes. But I think many of us believe that PCNs will not be disappearing in April 25. It would seem ludicrous for the government to do that, because the amount it will cost them just to do that will be astronomical with the setups that currently exist. It is more likely, as many of us suspect, that the funding will continue to go through PCNs rather than through practices. Whether that's correct or not, that is partly what obviously the GPC's role is with this, the BMA, collective action, all that kind of thing. But yeah,
I'm just thinking about in terms of the risks for employing organisations. So, I mean, could a GP be employed under this scheme for a fixed term contract? You know, that ends. Would that fly? I know you don't know the answer to this, so it's more of a question just to go out into the ether, really. Because with normal ARRS staff, you have to have the intention to employ for more than 6 months, don't you? But they'd removed that for this, and I just wonder if that opened the door to more of a fixed term sort of contract kind of arrangement, if that was what was being signalled there. I don't know if you had a thought on that.
So you're correct. I don't know definitively, and unfortunately, despite asking numerous times, we've not had an absolute clarification. And unfortunately, this clarification will need to come from NHS England at some point in the near future. Important to note that we are about to hit conference season. So both RCGP and best practice conferences, which are the two biggest conferences in general practices. And some of the people who probably should know this will be there. And absolutely, Andy and myself will be trying to ask those questions as best as we can. But if you wanted my initial answer, and again, I'm going to be very clear, do not stick to this for now. We will hopefully have clarification in the next few days or weeks. But my understanding is that you can currently employ a newly qualified GP under the GP and ARRS scheme for up to 6 months to then terminate at that point. However, the question of whether you can find somebody to take on that job is a completely different aspect, because, and this is the issue that we haven't touched on in more detail because we covered this in our previous episodes. These clinicians are going to be newly qualified. They're going to need a lot of supervision, a lot of support, because they are brand new, effectively, in general practice. And actually saying to them, we're going to give you a job, but only for 6 months at what looks like a fairly low rate of pay, is going to be a real challenge, I think, for many networks to make fly, and also to find individuals willing to do that, even despite the employment crisis issues that exist. Now, I think there are some innovative and potential solutions to that. We're not going to discuss that now,
no.
Because A, it's Sunday morning, we've been going for an hour. B, we have covered some of those in our previous episodes. And also, if you do want, and this is an absolute plug, and I apologize if this is going to annoy people, myself and Tara are going to be discussing this at the PCN Transformation Day at Best Practice. That's day 2, because we've got a specific session for that. So if you are coming to Best Practice, absolutely come and join us, because we'll be discussing this particular topic. And as I said, we will hopefully have a bit more clarification by that point as to the funding and employment mechanisms for these individuals. But the key thing is you don't have much time, is the long and short of it. Any thoughts, Andy?
Yeah, just echo what you said. I mean, I think there's a can of worms there in terms of what the impact will be of this scheme. You know, will it be attractive to individual GPs? Will it be attractive to PCNs? It's going to be very complicated to do. You can have small numbers of GPs and PCNs working in this way compared to large numbers working in a more traditional way. It's will it continue? It's a complicated one, isn't it? And I guess we'll just have to see and hear how it's working. Be interested to see at Best Practice if people have specific plans about what they're going to do. I'll be listening out for that there. Yeah, and I think Nina had sort of just having some thoughts about whether this will be attractive to GPs as well. So we had a few comments like that. So just to thank you, Nina, for your comment.
I think, like I said, there are some ways you can absolutely use this. I would love to hear what people are thinking about how they might want to use this effectively to both support those individuals and to make use of the funding. I suspect part of this is with a view to the government saying, well, you gave me some funding, but you're not used it. So you don't want it, blah, blah. I mean, this is a standard tactic that we unfortunately have seen in the past from previous government. It'll be interesting to see whether the current government use the same tactic or not. However, if you want to see some of those suggestions and what they look like, absolutely check out this episode where me and Andy talked about it. Alternately, come and join us at Best Practice. Come and join us at the RCGP conference. If you want links to do that, well, look at this episode. Well, there we are right there. There's going to come up in a second that shows you how to do that and the links to register and join. And absolutely, we'll continue to tech enhance your primary care and learning. And we'll catch you in the next episode. Have a great